So good morning. Thank you guys for the invitation. I'm really excited to be here. I was informed that there was a bit of a nice revelry last night, so I know that folks are a little bit tired and kind of waking up to the morning. So hopefully this will ease you into the end of your week. So I've titled my talk "Becoming an Effective 21st Century Bedside Teacher." I'd spoken to some of the chief residents to try to understand or get a sense of what might be helpful or useful at this juncture in the year. I think as we end an academic year and begin to start a new academic year, it's always a good time to pause and reflect and think about how we can continue to grow in our role as educators. Additionally, as one year goes to the next, we have folks that move in our GME programs in one role, and then as they move forward, find themselves in a greater educational capacity. So I'm hoping that what we speak about this morning will help to inform that. So I just wanted to kind of start with a little bit of interactivity, give you all a moment or two to turn to a neighbor or somebody that's near you, and just take 1 or 2 minutes to think about what was your favorite teaching encounter, why was it your favorite teaching encounter, and what about that encounter made it that way? So we can start to call to mind some of the things that make for an effective teacher. So why don't you go ahead and take a minute or two to do that with whoever's around you. Meet a friend, don't be shy. Why don't we try to wrap up in the next 10, 15 seconds? So before we move on, does anybody want to sort of shout out 1 or 2 things that came to mind as you were sharing this with your neighbor? Enthusiasm, great. What else? Anyone? Clarity. Good. I don't know, can our friends uptown participate? Yeah. Folks over at St. Luke's, what did you talk about? Oh, okay, good. Okay, I think I heard you say enthusiasm and attention to detail, so that's great. So keep this in mind as we go through the rest of this morning, and hopefully that spurs some reflection for yourself and your own teaching, and help you to put that into practice. So really I have 3 goals or 3 objectives for our session today. One is to connect adult learning theory to effective teaching techniques. The second is to describe how to provide feedback, and then I'll do at the end of the talk. And then lastly, list techniques for effective bedside teaching. We have a really broad audience here, and I think many of you are very experienced educators. So please feel free to share or chime in with your own thoughts about this. And hopefully what I'm going to try to do is provide a slightly different take or spin on this using some educational or adult learning theory, as well as some things related to why it's different to teach now than it was in the past. So one thing that I can say, at least for me in the last couple of years, that I've tried to take more attention to as I think about my own teaching practice, and whether it's I'm teaching at the bedside or I'm thinking about developing courses, is really the fact that we're at a point in our workforce where we have 4 different generations which are working together. Some of the folks are in the role of an educator, and others are in the role of a learner. And you can see here, these are the 4 generations that we have. We have traditionalists that are currently in their 60s to 80s. We have baby boomers in their mid 40s to early 60s. Gen X, which is really the folks that are in their late 20s, early 30s to mid 40s. And then millennials, which are now in the middle school, high school, college, and postgraduate phases. And depending on who we are, we may be in the adjacent generation, or we may be one removed. And that really informs how we think about how we learn, how they learn, and how we teach. This slide is really trying to summarize some of the differences across the 4 generations. And I want to just call some of that to mind as you think about how to become a more effective teacher. So when we look at the traditionalists and the baby boomer generation, they're really thought of as learning through classroom-based activities. And this isn't meant to say that people's styles of learning, their approaches can't change over time. But if you look at the generation as a whole, that's really how they typically have been taught. They tend to view education as and training as a perk or as a way to get ahead, and they tend to be really, they really value lifelong learning. The Gen Xers tend to use more facilitated learning, where they want to adopt technology-based learning formats. They want to learn in a continuous fashion and really value short, highly focused training that can be delivered in a mobile fashion. The Gen Ys or the millennials are independent. They really value the collaboration with peers as a form of learning and expect to have technology and hands-on learning. So that is an expectation for that group compared to the Gen Xers, who really are happy to have it in the learning setting, but it's not a requirement. They also respond really well to simulation and gamification, which is why you see some of that really in both higher education as well as postgraduate education. And Gen Z, which is our youngest generation, they really thought to learn through a lot of collaboration and networking, where technology and learning is designed to accommodate the needs of the students. So it's highly individualized, and they would like to see discussion and application of the content to the environment that they're going to be in. So with that, let's kind of go into a little bit about adult learning theory, a few things that I want you to think about as you then translate that into skills you can bring back to the bedside. So I will not bore you with theory, I promise, but I do think that it helps to put some names to some concepts that many of you may already be familiar with. So there are 4 things that are relevant to how adults learn, and it was Malcolm Knowles who really described this very well in the adult learning literature. And that learning must be relevant for an adult to be engaged. It must be problem-centered, must be active, and it must be experience-oriented. So when I say relevant, it really means that you're helping to fill a knowledge gap of a problem or an issue that's very proximal to the learner. Problem-centered, we are very familiar with medical education as we often learn through cases, and this is known to be a good way to frame items to really push an adult to get to their leading edge, to be engaged, and to want to learn. Lastly, it must be active. It should be the opposite a lot of what I'm doing this morning, which is really delivering, a lecture with a little bit of opportunity for activity, but it really should be engaging, right? You want the learner to be doing and speaking as much as possible. And it really changes the role of the educator. It flips the role of the educator from sage on the stage to really a facilitator of pulling and eliciting information from each of the learners in the encounter so that it's shared amongst one another. And then lastly, it should be experience-oriented. And that is meant to be both through experience one learns and also understanding someone's prior experience in that topic or knowledge that you can then add to that or augment it, as opposed to repeating something that they may already know and feel very comfortable with. Said another way, these are, the whole field of adult learning is also known as andragogy, and these are some of the key principles which I've already kind of mentioned. There is an intrinsic need for knowledge, and that inherently adults are internally motivated. I know at times that may not seem the case depending on the situation you're in, but at the end of the day, that is really how people want to learn, and we have to figure out how to tap into that in our educational roles. And there is an inherent willingness. It's just the key of whether or not we're matching that willingness to the current context in the situation to allow for a learning encounter to happen. It's built on foundation or experience of learning, and then there's self-direction. At the end of the day, adults need to be self-directed in order to learn. There's only so much that we can do face-to-face, and as there are many pressures on our time, we can't rely on face-to-face transmission of knowledge for folks to be able to learn and succeed. We have to kind of provide the catalyst. And the success is really if after we have spent our time with them, do they go on to continue to further their learning, knowledge, and skill development. And thinking about the orientation to learning. So these are some key principles that relate to adult learning. And the last theoretical piece that I want to share with you relates to transformative learning. So if you think about the adult educational field right now, we're really trying to push and understand how do we create transformative learning moments. And Jack Mesro, who's the father of transformative learning, was at Teachers College at Columbia, and he really created a lot of this body of work and has lots of disciples that are in various industries trying to help create this. And transformative learning really focuses on three things. One is identification of a dilemma or crisis. So it doesn't have to be big C crisis, but it could be something where you held a set of beliefs or the learner held a set of beliefs, and that through an experience, they're realizing that some of those beliefs were incorrect. And your role as the educator is to help them to make sense of that and to give them a new worldview. And that can be, I think that's really, really ripe for the clinical moments we have with our trainees. So we have lots of things that happen at the bedside. Patients get sick. People have conversations that are very crucial with patients, and thinking about how do we use those moments to really create a transformation in the way that people think. It has to, I think I've now mentioned that probably 3 times in the short time that I've started to speak to you this morning, but that's really critical. If it's not personally relevant to the learner, it's not going to stick. And lastly, it should foster and push critical thinking. We really need to have people engage in critical thinking for the learning to be sticky and meaningful. So I'm optimistic that over the next 4 to 5 years, we're going to see much more work being done in transformative learning. I think it's already started at the UME level, and I think we have to start to think how can we start to do that at the GME and the CME level as part of lifelong learning. So the next piece is safety. So there is a component to psychological safety which relates to how well or how ripe somebody's going to be able to engage in a learning encounter. So this is a graph, sort of theoretical constructs. On the y-axis, some fake measure or unit of learning, and on the x-axis you have categories of stress. So we know that in a low stress or no stress environment, there's very little learning, little accountability or consequence. And that in a high stress environment, however you want to define that, there's limited learning. People are they're not in a space where they can learn. They're usually either threatened, they're scared, or they're too overburdened to be able to engage in a learning encounter. So there's somewhere in the middle, which on this graph we've called mild stress, which kind of pushes people to really start to learn without being burdensome or threatening to them. And I think that it's important to think about that as we think about the tone that we set as educators, as we think about the way in which we use questioning. I'm going to talk about that in a little bit. And then lastly, what are the culture or environments of the teams that our learners learn in? So, is the team, which is really a microsystem, supportive of their learning, or is it, is it done in a way where they feel uncomfortable? So I'm going to switch gears to trying to give you some tips or pearls around bedside teaching in this era. And obviously, time, lack of physical space, all impinge on our ability to do the kind of bedside teaching I think that all of us would like to do and maybe have experienced as medical students or residents, for those of us that have been doing this for a little bit of time. So I mostly present this to you as quick things that you can incorporate hopefully into your work. Really anybody can apply these, so whether you're an intern, a resident, fellow, or faculty member, I think these are fairly applicable. So just some basics, so kind of teaching housekeeping 101 that will go a long way. Number one, using names in a learning encounter does wonders. It engages people like it's nobody's business. And I've particularly found that true with medical students, or if you have a pharmacy student rotating with you. It really pulls them in immediately and gets them engaged. It also shows a degree of respect for the learner. Patience, patience, patience. So we say that it takes on average 5 seconds for someone to hear a question, think about it, process it, and potentially formulate a response. Most people, when they've been observed in a teaching encounter, they wait 1 to 2 seconds before jumping back in. So for people that are new at this, really trying to count out 5 seconds. If you start to do it, you'll realize it feels like an eternity, but that starts to shrink over time. It's very important. And then for our learners that may be more introverted, that time may be longer. And so that's a dynamic that I would encourage you to start trying to pay attention to. To what extent are we privileging the extroverts in our group, where it's easier for them to sort of share verbally compared to those who are more introverted? And how can we try to draw out the folks that may be a little bit more quiet, or verbally sharing is not the easiest for them? Comfort. So sounds crazy, but I distinctly remember being a resident on morning rounds, and I was either hungry, physically uncomfortable because there was like nowhere to stand, or I had to go to the bathroom. So whenever I try to start the day, if we're going to do bedside rounds or we're going to do a mini lecture outside of someone's room, just do a quick check to make sure that people are okay. Like if you need to go to the bathroom, go to the bathroom. Because you're going to be far more engaged and paying attention if I give you that 2-minute break than if I make you suffer through something. And then distractions. And I think on the wards and in the clinic, this is a big issue, right? So it's that constant someone interrupting you when you're on rounds, it's the pager going off, people on their cell phone because they're getting paged or text. And there's not a really great 100% solution for it, but if you're the one sort of facilitating or leading the learning encounter, so if you're the resident running the team or the fellow running the team, think about what are the ground rules you're going to set around this, and how are you as a team going to keep each other in check? You know, you need to create some kind of protected space or time to allow for people to engage in the learning, because that's also part of the work of why they're here. So the next piece, this is really my graph to kind of try to push folks to understand the importance of doing stuff at the bedside and with the patient. So this is an authenticity matrix that I pulled from a really nice talk, which is on this free open source learning website for folks that do a lot of adult education. And you can think of this in sort of two matrices: authenticity of the sort of learning activity and the setting. So you can either be authentic, meaning right at the bedside for us, or it can be in the classroom. And you can be academic, or you can sort of be more real world or workplace based. And you can see we're really trying to get to the bottom right side of this. Real tasks completed in real workplace. That's kind of the goal, where we're doing learning and teaching and delivery of patient care all at the same time. Doesn't mean to say there's not a role for some of the other options. I fear, though, that for a variety of reasons, we've kind of moved into being okay with having those same conversations and talking about these patient-centered topics in a classroom, or doing flip card rounds, you know, in the resident workroom or the team room, and we're losing some real opportunity to do really workplace-based learning, which is what GME is all about. It is true workplace-based learning in a formalized setting. So just some tips to kind of begin to give you something to walk out of here with. So the first is setting goals. So it is daunting to think about providing patient care if you're moving into a resident role or fellow role, running a team, getting the work done, and I have to teach. And what I hope that I can do and others will reinforce for you is that it's really about doing something and making it a small, reasonable goal. And so when you go to think about incorporating teaching into the work that you're going to do, what is a small bite-sized goal that you can accomplish? And to help you set that goal, these are some tips. So one, kind of reviewing with students or interns before each rotation, what are our goals around the learning we're going to do together? And then communicating those goals. So if we're going to spend time talking about the differential of a rash on a leg, it would be nice for us for the person facilitating to say, our goal in the next 5 minutes is to really go through a differential for the rash that we saw on Mrs. Jones on her left leg. So everyone kind of knows where we are headed. It helps you to focus, it helps them to focus. And then if there's an assessment component at some point, it allies or aligns your assessment with what you taught. So how can you define them? So most of our educational goals come into 3 buckets. They're knowledge goals, they're skill goals, and they're attitudinal goals. And they should have a time frame if you're going to be formal about it. And the bottom of the slide gives some examples of that. And they can be, you can set a goal for that day, you can set a goal for that week, you can set a goal for the rotation. It's just a way to begin to create a roadmap so you and your learners know where you're headed together. The second relates to centering the learning on the learner's needs. And this is about the audience piece, right? You got to know who you're talking to. And one of the challenges, I think, for all of us is when we have teams with multiple levels of learners, how do I kind of make it work for everybody? And you can. You got to think about how you're going to do that. And this slide and the next slide are meant to try to help you to get some insight into that. So you got to teach them what they want to know, and you got to figure that out. For some folks, when they begin to do this, they come at their teaching role with such enthusiasm and passion, and they also have a lot of passion and interest in a particular area, and they sort of want to just deliver that type of teaching. So I've seen that with some residents who have been like extremely enthusiastic about cardiology, and all they wind up doing with their teams is teaching a ton of cardiology, but they're on a gen med service, and the internal medical student are like, I learned a lot about cardiology, but I know nothing about sort of the rest of the stuff that we saw. So don't let sort of enthusiasm for a certain topic wind up sort of hijacking the agenda. Diagnosing your learner, so asking or trying to figure out where they're at with a certain topic. That can be done either explicitly or through a series of questions. And I really like to use questioning as a way to kind of get a sense of where people are at, but also to allow me to teach to multiple levels. You can think about questioning as having different levels, and this ladder on the one side of the slide is kind of calling attention to that. So you have remembering certain facts, you have a level of understanding or explaining, you have application type questions, how would you actually use it? You have analysis type questions where you're actually pulling things apart. You have evaluation type questions where you're asking people to rank or to make a judgment or a decision about some items of information. And then there's synthesis, which is really pulling it together. So for those of you that are very familiar with education, you've probably seen Miller's assessment pyramid, which is a way to help think about the different levels of performance, or the knowledge and then applying it to performance. And so at the bottom you have knowing, and that's really the items related to knowledge. And then you have knowing how to do something. So I can know what a central line is and where it needs to go. I can then know how I would put it in. The next step would be showing how, and that's really where simulation and demonstration comes into place. And then lastly is doing. And doing is really at the point of care. And in my mind, our goal should be, how do we push the work we do as educators closer to the top of that pyramid so that we're being as authentic as possible? And questioning can begin to help us with that. And so this is a slide I took from a book written by a professor at Harvard Business School, where they use a lot of questioning and the Socratic method to try to do really big, 90-person case-based learning. But he talks about the different purposes that questions serve in a dialogue. So, right, we ask questions for a variety of reasons. We don't often think, we don't bring to attention why are we asking that question. But I would encourage you, as you start to be more deliberate in your teaching, to think a little bit about what is the purpose of why I'm about to ask this question. Is it to gain learners' participation, right? So kind of what I did at the beginning of this talk was really to get you guys to start to participate. I didn't have enough time to get a report out, and I really wasn't looking for all the details about it, but it was really to get you to start thinking and talking. To determine what the learner knows, so that's the diagnosis part. Sometimes you do it to focus attention on the learner. So if we have somebody that's disengaged, sometimes asking a question in a polite way helps to re-engage them in the conversation. It could be to lead a discussion, to review subject matter, or to stimulate thinking. And then lastly, it could be to test the learner's knowledge of subject covered in class. And there's probably many, many more, but think about the purpose behind your question, and that will help to better inform how to formulate the question. And this is my slide, which kind of relates to some of what Sanders talks about and how other folks have taught using this technique. So you have open-ended versus closed-ended questions. Our natural inclination is to ask closed-ended questions, right? We love to ask binary questions without realizing we're asking a binary question. And these are examples of questions that you can incorporate into the way that you do case-based or patient-based teaching, which really relate to diagnosis. So how do you interpret, how do you explain, are awesome kind of taglines to get people to share with you their thinking. Challenge questions. So really pushing people to say, why did you choose that? Or why do you want that approach? Or how would you explain that? I'll get into a little bit. Priority questions and then action questions we'll talk about. So I'm going to skip this for a second and then we'll come back to it if we have time. The third tip relates to extending the case. So to a certain extent, a lot of us see a lot of the same stuff, and our residents and fellows medical students see a lot of the same stuff, right? So there's a lot of pneumonia, a lot of heart failure on the inpatient side. If you spend time with me in my office, you'll see a lot of IBS and a lot of constipation. It's our job to figure out how to keep people engaged and what else can we use those cases to help people learn. So extending the case is one way to do that, and it's super easy, right? So we can change a variety of variables to help extend the learning encounter. So you can change a lab variable. And I really like doing this in the outpatient setting. So if I'm reviewing labs on a patient with somebody I've just had an encounter with, and I say, well, what if you get that lab back and the AST and ALT come back at 400 or 500? How is that going to change how you respond to the patient? What are you going to do next? Change the age. So as geriatricians, this is a perfect way to teach geriatrics. And this was the way that when I was a Geri fellow, I was able to try to engage some of the house staff in actually getting to pay attention to why this made a difference. So usually I was going to the bedside to see a patient with them where the patient was, our average age on our census was like in the low 80s. So I would flip it and I'd say, well, how does this compare, or why is the physiology of sepsis different in somebody who you've taken care of that's 25? And let's compare and contrast these two. How does that change the way that you approach how you're going to sign this patient out and what you're going to look for? Think about changing the setting. Great opportunity if you're admitting somebody from the ER and you want to flip it on their head and say, what would happen in the clinic, or what would happen if you were on the wards? And then as we go into July, the anticipatory guidance. So what would you do if the patient spikes a fever tonight? Why? How would you sign this patient out to your covering colleague? These are all different ways to extend the case and really push people to think about different elements of the topic. The next tip is really about how do you save time, right? You're really busy, you got a lot going on, and I have to somehow figure out how I'm going to teach today. That can be daunting and overwhelming. Remember, whether you're a resident, a fellow, or an attending, probably some of the most valuable things that we can do are to share with our learners what's going on in our head as we're approaching the case. And that's a really efficient way to do some teaching. So sharing or speaking aloud your clinical reasoning has a lot of value, and we probably don't do that enough. I think that for those folks who teach that have been in practice for years, I think getting some of that wisdom of how did you put this case together is really valuable for really everyone. And doing that will save time. And then lastly, role modeling. And I think role modeling has many, many, many benefits. And again, probably a technique we don't go to enough. So you can role model an exam skill, right? How do I examine the belly for ascites or to palpate the liver? And modeling interaction with patients. And I actually wish, if I could go back, I probably would ask more of my attendings that taught me to role model some key types of conversations that I didn't get enough time to watch. Because it's something that we struggle with, and I think until you're sitting in that chair alone in the room with the patient, you don't really know kind of how you're going to do this. And we all learn over time, and hopefully people are reflecting on when they're having these conversations. But watching this is probably one of the things that is, residents who've had some experience, attendings who've had a lot of experience can share. And not just saying, come and watch me, but make it deliberate. Say to the learner, we're going to go in and I'm going to talk about this CAT scan where there's a malignancy. And I want you to observe. I want you to watch what words did I use? How did the patient respond to the words I used? And what was the body language? And then when you come out of that encounter, take 30 seconds to say, share with me what you saw, and debrief that. That is something you can do within the moment and has so much value. And lastly, modeling self-directed learning. So on teams, it's not uncommon for us to hopefully ask people to go and follow up on something or look up something and then bring that back to the team. That's great, sort of team-based learning culture. You in the senior position should do that as well. If they see you do that, they're going to be more encouraged to role model and emulate that behavior. And then it really does show that this is not just about learning when you're a resident or a medical student, it's about learning for the process of the course of our career. And then making a small commitment. Again, this is about efficiency, and we all get that we have multiple different demands on our day, but even if we focus on one patient for the day, we did bedside rounds with a few patients together as a team, we spent 5 minutes on a topic, any of that counts, and it will be value added to everybody that's involved. So those are really my kind of like quick and dirty tips for what you can hopefully take with you today as you go back out to do your various roles. I wanted to then switch gears a little bit to talking about technology and bedside teaching. And while there have been courses that have been created to talk just about this, I'm going to highlight a few things that I think are important. If you get a chance, Eric Barna and Dennis Chang have faculty development material, which they've created a really nice 90-minute workshop, which I know that they've done through the GME Educational Conference. They've done for the Department of Medicine. I think Eric and Dennis have both recorded short snippets on our GME faculty development website. If this is a topic of interest to you, I would encourage you to go take a look at that for further learning, because it's great stuff what they've thought about and put together. So this is really a bunch of stuff that's at your fingertips. So this is accessible with a smartphone, a tablet, or a computer. Guidelines we can pull up on our phones. Most of our professional societies now have apps that allow us to access our most common guidelines, and we should be really pulling that stuff out as we're having conversations so we can show folks and demonstrate how we're getting the most up-to-date evidence. Images. So there are data banks of images, but some of us also keep our own, depending on what kind of work we do, some of us keep our own file of images of either really interesting x-rays, really interesting physical exam findings, either keeping them obviously in a HIPAA compliant way on a Dropbox or on your phone if you have a folder for photos. That's great stuff to just pull out and reinforce while you're on rounds. There's a lot of shared resources. I mentioned there are a variety of databases and repositories for EKGs, for chest x-rays, for PATH. MedEd Portal is another resource which if you haven't heard or used, I encourage you to start using it. It is a peer-reviewed repository for a variety of educational curricula across the spectrum. So there's stuff in there for every level of learner. There's stuff there for PAs, for NPs. It covers all kinds of topics across all 6 competencies, and it's not specialty specific, although you can find specialty specific material there. If you are in the role of a clinician educator and you have stuff you've created that's great, you should submit it to MedEd Portal, get it peer reviewed, and they will publish it, and it counts as a publication. And actually, I just learned last week that they are going to, they are in the process of becoming recognized as a formal journal. So then the items will be indexed. The other thing as an educator that it does is it tracks the number of views or hits you get, and people that use your products can actually give you feedback. So from thinking about it from an educator, this is great data you can then use to show the impact of your work. As somebody that's teaching, you don't have to go and reinvent the wheel. There's tons of great stuff out there. You can download it, and it's there for you to use. So you don't have to spend all this time sitting at home and creating material on your own. And lastly, board review questions. And I think almost all the major board review products now have a tablet or an app-based way to do board review questions. When you have downtime or you're waiting or you're sort of like, I didn't have time to prepare very much, and you pull out and do a couple board review questions, that's a great way to stimulate some learning. The next is about the EMR. So I think that the EMR has been thought of as a big hindrance to our ability to do really, really effective bedside teaching. And some folks would say it's the thing that's taken us away from our patients. It's the thing that's taken away our residents and teams away from being at the bedside. And the literature is a bit mixed. So I found this paper, which is the reference I have below, which was a mixed methods qualitative and quantitative study, which looked at 12 different institutions that had EPIC. And they interviewed about 50 people that were involved in residency and fellow education. And they were asking questions about the impact of EPIC on teaching. And they did find that there was some value in the EMR if leveraged correctly. One of the things they found is that their qualitative piece was saying that people felt that it was helping them to teach clinical reasoning. But there was an interesting editorial which came out in that same issue, which was sort of saying that that can't possibly be true and that we need more studies or learning around this. So the tips that they do mention, so before I actually get there, let me just point out to you some of the things that exist within the EMR that are quick and dirty, easy things to create learning moments. Number one, the problem list. So if you have an inpatient, we tend not to usually go back to the main problem list, which may house some of their outpatient issues. Always a good thing to go back to and then say, how do some of these things relate to what we are doing now? Or how are we going to think about managing these conditions as we transition them back to the home or to the nursing home? Prior imaging. I love the fact that we can get any kind of imaging because there is a data bank of stuff there, right? So if you know that this person came in a year ago for a cavitary lung nodule, but they're here now for a GI bleed, yeah, you've been focused on the GI bleed, and maybe we've kind of exhausted the GI bleed learning, but maybe it's worth looking at that cavitary lung nodule image because it's kind of interesting. And maybe that relates to something that's going on with the patient. And then old EKG. So that's stuff that's just sitting there that we can mine to create learning moments out of. These were the tips that came out of this paper about how to use or leverage the EMR. So number one, we have a huge opportunity to use the review of notes as a learning moment. So what they recommend and what I think folks have found useful in practice is if you are reviewing notes, try to review them together. If you're sitting in your office at the end of the day and reviewing notes, think about keeping a little scratch pad or notepad to make comments of the things that you are finding in the notes that really deserve legitimate feedback. And so that it's not just that the resident wrote the note and then forwarded it to you for co-signature. Using the EMR and the note as a way to teach billing. It's an important thing that we need to do for our residents and fellows. And for, I don't know here if you guys are doing inpatient epic billing, but certainly we're doing it on the outpatient side. It's a great time to say, before you close that chart, let's go through how we're going to code this visit. And lastly, leveraging templates, order sets, and smart sets. So if we're admitting a patient with CHF and we're going to use CHF order set, maybe we should sit down with the learner and go through, why are these things included in the order set? And why are you choosing one or the other item? And what's not included in the order set that you may be used to using to treat this condition? Because in theory, and I think in practice as well, our order sets are created based on evidence and guidelines in a good way to sort of reinforce that. And then lastly, feedback. So feedback should really be part, in my mind, part and parcel of every learning encounter and the way that we do work. My recent focus has been on how do we create teams where there is a team-based feedback culture. So it's multi-directional and it is just part of the way that we do work. And it's done in a way that people find useful and actionable and not threatening, punitive, or judgmental. So feedback in its truest form was first written about in medical literature by Jack Endy. And he said that it was an informed, non-evaluative, and objective appraisal of performance intended to improve skills. And remember, feedback as a concept kind of came out of the aerospace industry. As engineers were designing rockets, they wanted to find ways for the data that could be sent from the rocket back to Earth so the engineers could know what the trajectory of the rocket was. So feedback in theory should be data that we're putting back out to the learner so that they can readjust how they're getting to their end goal. It is different from evaluation, and I really want to emphasize this, and the bottom table is meant to highlight the differences. Feedback should be ongoing day-to-day, and it should be objective. Evaluation is really a summative assessment. It is meant to provide a judgment. It's a judgment against hopefully a set of validated standards, and it uses adjectives and adverbs, and it occurs at scheduled intervals. So sometimes I hear inpatient or outpatient faculty saying, I definitely give them feedback. We sit down at the end of the month and I give them feedback. I'm like, that's actually evaluation because the engagement of your learning with them is ended. You're about to give them verbal feedback, what you're calling feedback, to then write what is an evaluation in a learning management system. So the feedback should really be, during the course of patient care, maybe at the end of a session, at the end of a day, at the end of a procedure, so people can, in the moment, get that information and hopefully do something with it. Our goals are really twofold with feedback. One is to address areas where the learner is performing at a high level and to call that to their attention and say, that you're doing really great, keep doing it. The second is to highlight the gap between their performance and what you expect for the standard. And to identify that for them, and two, to help figure out how they're going to close that gap. So it's not just enough to say that you're really doing an incomplete abdominal exam for this, and this reason. You then have to say, how am I going to help you to get better at that? And some tips, just there's many ways to do it. Some folks like the feedback sandwich, which is the good, positive or reinforcing feedback followed by negative or corrective feedback, and then followed again by the positive reinforcing feedback. I personally don't like that approach because I think it's not a dialogue, and it seems for some folks to negate the item in the middle, which I think is really important. Instead, sort of borrowing from the palliative care literature, there have been folks who've written a really nice article about ask, tell, ask. So it's really creating a dialogue. How did that patient encounter go? They tell you how it went. I then tell them what did I observe and my feedback. Then you ask, what questions do you have for me, or what are the next steps you're going to take or we can take together to do this the next time? So it really changes it from I'm just going to tell you and sort of dump this on you and let you figure it out, to a real dialogue. The other piece about this is think about, should you be getting feedback on your own teaching, right? So maybe you start the conversation with, we just finished that really difficult colonoscopy. How was it for me to precept that case for you? What did I do that was helpful to you? Where could I have been more supportive of your learning? And then say, how do you think your performance was in that case? And then give the feedback. And that really, again, that helps to create a more, I don't want to say even, but it certainly creates a more engaging dialogue as opposed to this feeling very one way. Constructive and reinforcing, so those are the new words I'm trying to incorporate to try to move away from positive and negative, so that people don't feel like there's this valence attached to what we're giving to them. And then be an observer. So you cannot give feedback as an educator if you are not watching, right? So this is the part that always makes me now laugh, but it used to make me cringe when I was more involved in fellowship. So there are faculty I know sit in the precepting room the entire 4 hours. And then I go and read the evaluations of the fellows. And there's comments about physical exam skills, about talking to patients. I'm like, how possibly are you getting this information? Because you did not get up and go watch them, right? So we need to have data in order to be able to do that. And that means being at the bedside and watching them do things. Everyone has their own way of how they keep track of it. I used to have index cards that I would just quietly make some notes, and then at intervals I'd pull them out and we'd talk about it. Other folks use the notes feature in their iPhone. I mean, there's many ways to do it if you don't think you can get feedback in real time. And then the last piece, which is sort of at least for me, where I've been spending a lot of my time really thinking about how to kind of push feedback or understand feedback a little bit better, relates to the way in which we learn. So very crudely, you can think about adult learning as task, process, and reflection. So a lot of the work we do is focused on task and process and sort of ends there. And I know that in a lot of the safety work we talk about, we really sometimes get sucked into just staying in that area. But the larger amount of learning comes from the reflection, which is harder. And for some people is not a natural place to go. Formally, Argis and Schoen in the 70s wrote about this as single and double loop learning, which has been applied to many areas. I think organizationally, the military has taken this on and really applied it in a really thoughtful way. So when they do simulation exercises or they have an event, they engage in this reflection process. They then catalog their learnings, and that information is available to every mid and senior leader across the branch of the military. So if I'm then going in to do a sim with my team on X topic, I can look and see what have been the learnings already from other teams that have engaged in this activity. So single loop learning is saying you have strategies and techniques. It's what we do and then the results we get. So if you just live in that spectrum, you're really just saying, well, you did this and this happened. And you may say why, and they may give you a very technical or process related answer. And what I want to try to have you think about is to really get to the underlying assumptions of why what was done was done. And so this means really trying to ask questions about the underlying assumptions, the underlying values. What are beliefs that the person is holding that's making them behave in this way or engage in the task in this way? And when you get to that, that's really where you have the crux of how you can start to fix. And if you think about that transformative learning slide, that's what Mesereau was talking about. So if you can get at the underlying assumption and create that sort of, whoa, I've always thought about this way, and maybe that's not really the case, that assumption I held was wrong, then you have a great moment to start to build and create a learning moment. So that can be done in a variety of ways, usually through asking more questions around why or really pushing them. The 5 whys is a good technique because it really gets you to the belief that they're holding. So really, I have 3 take-home points. Adults learn when there's a problem to solve and it is active. Teaching at the bedside can take many forms and can be bite-sized. And lastly, feedback is a key part of any teaching encounter for adults. And I hope that you'll think about how to incorporate reflection into that so you can make it a more stickier learning encounter. So with that, I'm more than happy to take questions or hear discussion if folks want to share their own experiences.
question from same groups. Excellent talk, and I really enjoyed it, especially because I want to be a medical educator myself. So I wanted to know something about your experience in procedural learning, because you are well known as an endoscopic educator yourself. So it's often said about colonoscopy that it's the first new skill that you learn since learning how to ride a bike. So I wonder if you could tell us something about how you implemented some of these strategies in colonoscopic teaching. And my follow-up question is that let's say if an experienced GI who's like 10 years following his fellowship decides to learn a new advanced skill like endoscopic suturing. So would a learning curve for a 45-year-old GI with 15 years of experience under the belt differ from someone who's fresh out of fellowship but a younger guy?
This is a great question. So thanks for your comments. So procedural teaching is something that we've started to venture into learning about. It actually was a big portion of some of the sessions at our national meeting that just ended a couple days ago. So the first thing is, what kind of tips or what have I thought about in terms of it? So people have written about procedural teaching models. Actually, the surgical literature is filled with them. But actually, there is some nice work that we use in our chief resident retreat that talks about how do you teach, sort of smaller procedures, so exam skills or bedside procedures. And some of that is kind of using the things we know about going from a novice, sort of being incompetently competent to being a competent expert, and really using both role modeling, a lot of explanation before actually going in and starting to do something, and then feedback. So I think the thing that we found is that our fellows feel that they're not getting real-time feedback after they've done a procedure with an attending. And so some of our faculty development work has really been in trying to help the faculty to understand how to give that feedback. Conversely, with one of our third-year fellows, we've spent some time trying to elucidate what are the teaching behaviors in endoscopy that make for an effective encounter. So we've done a qualitative study that's now going to be translated into a tool that we're going to have the fellows fill out after cases, and then hopefully can create some feedback for the attendings that summarize and say, here are the things that you've done in an endoscopic teaching encounter that they found useful, and here are sort of opportunities for further learning. Your second question about teaching advanced procedures. So the advanced endoscopy world has spent a lot of time thinking about this, particularly around EUS and ERCP. So we're now at a point where we're beginning to see training curves of the number of procedures needed for competence and to meet certain quality metrics. I think it's a little bit hard to say what's the one-size-fits-all of at what point in your life is it easier or harder. To a certain extent, these are all psychomotor skills. And so if you've been in practice for 10 years and you've done thousands of EGDs and colonoscopies, you have honed some component of your psychomotor skills. So it's easier for you for your hand-eye coordination. Depends on the skill you're learning, though. Some of the new endoscopic techniques are quite challenging, and I don't think we completely know how to teach that. We do know that there is probably a formula to learning the knowledge behind it, having some degree of simulation, and then having some precepted activity. But I think, like endoscopic suturing, we haven't quite cracked that learning curve yet. I think we'll get there. I think POEM and some of the other minimally invasive techniques are going to be the next frontier.
Thank you. I just have a question from a different perspective. Namely, do we know anything about the impact of bedside teaching on the patient and the patient's experience? And is the patient able to actually contribute to the feedback process?
Great question. So I haven't spent a lot of time on that part of the literature. There are two papers that come to mind, though. There was a study done looking at, it was an internal medicine study. It was on the wards, and they randomized the teams. And one team, that group of attendings was given faculty development on feedback and told to provide structured, deliberate feedback to the team. And then the other, it was kind of business as usual. And they were looking to see, did it change the HCAP scores? Now, the instrument is inherently a dirty instrument, but they started to see a signal that the patients in which the teams that were getting more regular structured feedback did have better patient outcomes. I think that there is literature around patient retention about their disease and things related to teach back, where bedside teaching can have an impact. But I do think that that's something we should look more closely at. We do know that trainee involvement in many of the settings does not seem to negatively impact and may in fact enhance it. So I think we need to, and I think this is something that all of our hospitals need to really start to look at and be able to communicate the impact of the value of that as we start to think about being more patient-centered. Dr. Smith.
I'm not going to ask you a GI question, I promise. I want to have you balance your CMO hat with your teacher mentor hat. And that we have implemented a lot of real-time communication technology to make our care more efficient, to try and speed up the care, drop length of stay, et cetera, whether that's paging, smartphones, et cetera, 24-hour accessibility. But a lot of those technologies, for those of us who remember teaching and leading groups before all of that was so rampant, we used to be able to teach in a less interrupted way. And that we didn't have people constantly feeling for the vibration on their hip and then looking down and typing something quickly and looking up and then 10 seconds later doing the exact same thing over and over again. And that, I think those of us who have taught over the continuum would say that the quality of what's actually being absorbed in the brains of those being distracted is going down, both quantity and quality. And I'm interested to hear your perspective on how we can structure those teaching experiences, whether it's on rounds, whether it's formalized teaching sit-down sessions, to balance the need to be accessible to our colleagues and others that are providing care to maintain the efficiency, but not lose that essential teaching component, because it seems like right now we haven't found the balance yet.
I agree with you. I think it's a great question. So I'll give you two perspectives. So the first is sort of when I was more involved in fellowship and running a consult service, right? So those days were busy, erratic. You generally had no sense of control. So when I would start on service with the fellows, we sort of have this conversation about, 1, how do you like to learn? 2, what do you want to learn? 3, how are we going to structure our day? And it was a negotiation. Part of my negotiation was, I want to make sure you learn every day. But part of the way we need to do that is find the space where things are quiet and you are not being interrupted. So for us, that was 7 to 7:20 every morning. So they get sign out, you come to my office, we sit, and for 20 minutes, that is your time. Don't answer any pages, nobody interrupts you. The other time was trying to communicate to the rest of our team the critical moments when it was important that we not be interrupted in certain tasks. So for me, the moments after finishing an endoscopic case and the fellow writing the note is important. And if I don't review that note correctly, number 1, we're going to have a problem around the accuracy and what's in the note. 2, I've lost my opportunity to provide feedback if I try to wait till the end of the day. And so I tried to communicate to our nurse, our endotech, and anesthesiologist, you need to give us 3 minutes to be able to do this. It is like a timeout. We will get to we'll make sure the rest of the world runs efficiently, but we need that time. The other thing at Queens, where I don't have residents and fellows, we have PAs, the learning is a little bit different. So we have a weekly sepsis meeting where there's a weekly sepsis case review. So the nurses know on the floors that our PAs are going to be engaged in a case review where we use that to try to do some learning and teaching. And by and large, they try not to interrupt, and the PAs sort of know that they're not going to leave unless somebody's truly sick or crashing to be able to do that. So I think some of it's setting up ground rules and expectations. I think the other piece is, what are the things that we do that we consider as work that we're not extracting to create a learning moment around? And some of that might just be, again, vocalizing the stuff that we think is routine and they may not be interested in. But when I would put in my endoscopic charges, I'd be like, let's do this together. So what do we do? What do we find? And what procedures am I billing for? Why is that important? And understanding that. And I can't take credit for coming up with that on my own. Jeff Farber was my geriatrics inpatient teaching attending. And over lunch, several times during my 2 months with him, because he had access to all the billing systems, he would take a patient that we saw And he would go through every charge with me. And he's like, this is what this cost. Here's how the professional fees flowed. Here's how the hospital bill flows. And that was really valuable just for me to understand that the impact of what gets paid for and what doesn't get paid for. So hopefully those are some things, again, setting up a culture.
Great talk. Just a quick anecdote just to finish with, because we have some of the same mentors. But Freddie Schiffman at Brown, I remember him telling this anecdote about one of his favorite residents, who he said was a really great resident, and then he one day decided to go to the bedside with the resident, and he was examining fundoscopy, and the resident said, everything looks normal. And as Fred was observing the resident, he noticed that the light was shining in the resident's forehead. So you actually had your ophthalmoscope faced the wrong way round, and was just in this sort of sense of anxiety saying, yeah, it looks great. And you're right, so sometimes you just can't do these card flips, you have to take it to the bedside. But thank you for a great talk.
Thank you.
Thank you very much.
My pleasure. Thank you guys. Have a great day.